have all of the AHEC scholars here today joining us. Just to give a little bit of background, the Scholars Program is an interdisciplinary program across the state who are learning about different disciplines and then hopefully going back to serve in rural areas around the state. So thankful for them to be able to be here today, but also that they are participating in the Scholars Program overall. I think one of the requests that our Scholars coordinators had from the different centers is to, if you guys would write in the chat box your name. Actually, I'm going to let Rachel jump in here because Rachel, and I'll introduce Rachel Watts. She is working with us with AHEC, and so excited to have her as a coordinator with our social media programs, but also stepping in and helping plan programming for scholars as well. So Rachel, thank you for being here. She started with us as a Vista and is now working with us a little bit more than she was with as a Vista as a coordinator. So Rachel, go ahead. Thank you for being here.
Yes. Hi, I'm Rachel Watts. I am, as Dr. Ramey said, I'm the digital media coordinator for the Alabama Statewide AHEC program office. I'm the one coordinating these webinars right now. So if you have any webinar topic requests, feel free to reach out to me via email. I have been emailing you guys, so you should have my email. The coordinators wanted you guys to drop your names in the chat along with your discipline and your university that you go to, so that they can keep track of everybody. So if you guys will go ahead and do that, that'll be perfect. Today we have with us Dr. Pia Sin. She is from the UAB School of Public Health. She is a tenured professor and the Blue Cross Blue Shield Endowed Chair in Health Economics. Her primary interest is investigating the determinants of health for vulnerable populations with a focus on the role of policy and interventions at institutional, state, and federal levels. So she is the one who is going to be talking with us today. Dr. Sin, are you ready?
I am. I just wanted to make sure I can share my screen. So
yes.
Okay.
I made you co-host, so I'm pretty sure you should be able to get that option.
I'm just going to test that out before I start.
Okay.
Let's see.
Yes.
Okay, that's going to work fine. Well, thank you so much, Rachel. Thank you, Dr. Ramey. Pleasure to be here. I'm Dr. Bishaka Sen, but I go by Pia. I don't think anybody at UAB remembers that my formal name's Bishaka. So I'm a health economist and a health policy researcher. And so what I really wanted to do today was talk a little bit more about the one topic that I think is of great interest, not just to health policy professionals, but also to healthcare providers, which is the question of Medicaid expansion in Alabama. So that's what I wanted to get into. What I was also going to try today, and I sent my request to Rachel, is for the first time ever actually try a Zoom poll. Rachel, did that work?
Yes, we should be able to do that. You just let me know when you would like me to put them out.
So actually, and do I need to stop sharing my screen for us to do a Zoom poll?
I think it'll pop up regardless. Would you like both of them at the same time?
Oh, well, let's start with the first one.
Start with the first one?
Yes.
Okay.
Please.
I'll go ahead. All right, you guys should be able to see it.
Can I just say the Zoom poll is incredibly cool? The fact that I can see it on real time.
It is.
All right, we'll give it one more minute. We have about 64% participation right now, and then I'll move on. Well, so far from what I can see of all those who have participated, about just a little above 20% are actually not familiar with the term Medicaid expansion. And about 78% of those who participated said they are familiar. So that's good. Most of you have some idea, but for those who don't, I always like to start with a general overview of what is the Patient Protection and Affordable Care Act, and then sort of go on to the specific issue of Medicaid expansion. And I would want to acknowledge my colleagues, Dr. Mike Morrissey, Dr. David Becker, also Professor John McDonough from Harvard, who was here last year to give a talk on this topic and has very kindly let me use one of his slides in part of my presentation. And finally to Mr. Ryan Hankins, who is for PARCA, that's a nonprofit institute that does research for issues particularly pertinent to Alabama, and I have worked with him very closely on this topic. We've been on several panels together. So, Rachel, what's the best way to do this if they have questions? Should they put it in the chat or just unmute? How do you typically like to do it?
They can put it in the chat if they would like, and we can pause in between slides and we can read them off. Or if they would like to ask you directly, they could probably, I think they should be able to like raise their hand.
All
Should be
right.
like a little button.
And you'll be able to monitor that, right? Because I'm seeing my slides. Okay, perfect. So I'm going to sort of put in little breaks between my slides to see if there are questions. But if you have a question as I'm talking, just raise your hand and Rachel will alert me. Perfect.
Yes.
So just for a little bit of background, the Patient Protection and Affordable Care Act, which is sometimes just referred to as Affordable Care Act, and sometimes referred to by its popular nickname Obamacare because it was done under President Obama, that got signed into law in 2010. And what the PPACA was trying to do was finally bring universal health care to the United States after several attempts under other administrations that didn't really get off the ground. And so what the PPACA is, it's modeled after the universal healthcare system of several Western European nations, especially has very strong similarities to Scandinavian countries and Germany, and to some extent, not perfectly, France. One of the things that I see a lot of people wondering is when a lot of people hear universal healthcare, they think of it as the British model of universal healthcare. And the way the British model of universal healthcare works is basically if you think of an expanded VA, Veterans Administration system for across the country, where all the doctors are basically government employees. And this is completely funded via some mix of taxes and then income level specific contribution. So that's the British model. It's also the Canadian model with the modification that in the Canadian model, each province runs it, not the central government. But that is only one model. And the European, Scandinavian, German models are also very common, where it's basically the doctors and the hospital systems essentially are private. They're not government employed, but there's basically a contract through which individuals sign up for different plans that give you different levels of access to the doctors. But what's really critical is nobody can be told, oh, you're going to get charged an incredibly high premium because you have a pre-existing condition. That is not permitted. And also, it's essential that these systems have as much of the population as they can in there because there's something that's called pooling risk. And you need to have people who are generally young and healthy in the pool because you want to keep the average premiums low. And I always say that this is nothing to do with your political philosophy. It's everything to do with algebra and the rule of averages. So what's the main provisions of the Affordable Care Act? Basically, it prohibits denial of coverage for pre-existing conditions. Before Affordable Care Act, if you didn't have health insurance through your employer and you tried to get it through the private market, you'd basically be asked to fill in a list of, current health conditions. And if you had what's called pre-existing conditions, you could either be denied coverage or you could be charged an exorbitantly high premium for your coverage, or you could be told that, yes, you can have coverage, but by the way, we are not going to cover anything related to pre-existing conditions. And then it was often the case that when you needed coverage, the insurance company would try to prove that it was somehow related to your pre-existing condition and deny you. All of those things were problems. So first, the biggest thing it did, the Affordable Care Act, is it said that plans purchased through its health exchanges could not deny coverage or charge higher premiums for pre-existing conditions. It also made the provision that adult children up to the age of 26 years of age could now just be covered on their parents' health insurance plans. So previously, adult children would age out much earlier than that. I think they aged out at around 21 or 22. And because it was considered that up to 26, people often, maybe part-time working while they're still in school or they're exploring their employment options, it was just easier for families if they stayed on their parents' health insurance plans. So basically, there is a community rating for the way premiums were being charged in the markets. So no risk adjustment simply means you could not be charged a higher premium for pre-existing health conditions. So the only thing that they will ding you for is if you're a current smoker. If you're a current tobacco user, you get charged a higher premium. No gender adjustment. Previously, private health insurance companies would often be like, well, women get pregnant. And so there are these excess costs because of pregnancy and childbearing. And so we are going to charge women a higher premium. That is not allowed. And so the premium that you do pay on these plans is based on your age. So as you grow older, yes, they do charge you a higher premium. And then also based on your geographic region. Each state has its own health exchange, and that's where the different companies who are offering plans actually offer those plans. And all of those plans have to cover some essential health benefits. For example, they have to cover preventive care, a whole range of preventive care, screenings, etc., without any co-payments. So ever since, and this was adopted even by all other plans that were not on the exchanges. So for example, now when I go for like a mammogram, I don't have a co-payment for that. Okay, so how were they going to ensure that there was, in fact, universal health care through the Patient Protection and Affordable Care Act? Well, as I mentioned, every state was going to have a health insurance exchange. States could set up their own health insurance exchanges, and if states didn't want to, the federal government would set up one for them. And on that exchange, all of these companies would offer these plans, which were all subject to the fact that you couldn't charge extra for pre-existing conditions and you had to cover essential benefits. The way, this is the critical part for our talk, Medicaid expansion. The way really low-income people were going to get covered was Medicaid plans, which till then had mostly been for low-income children and low-income pregnant persons and low-income people with certain health conditions like a diagnosis of breast cancer or colon cancer, only they were covered. Medicaid expansion was going to cover everybody, including adults without children or adults who didn't have a disability, up to 133% of the federal poverty line. So the federal poverty line changes from year to year, but right now, I think it's in the ballpark of, for a family of 4, it's in the ballpark of about $30,000 per year. So 133% of the federal poverty line would mean family income till 30,000 and 33,000 adding on. So roughly family income of up to 40,000, all adults would be covered. That would be the Medicaid expansion provision. And then for people who were above the poverty line, so you're covered till you're 40,000, to income of 40,000 for a family of 4, but then from 30,000 onwards, you can also get this provision where you buy on the exchange and you get a discount based on your family income. And the discounts go all the way up to 400% of the federal poverty level. So that would be 30,000 multiplied by 4 for a family of 4, all the way up to an income of 120,000. You would get some kind of a premium discount or a premium support, as it's technically called. And President Biden has actually further expanded those premium credits under the Inflation Reduction Act and the American Rescue Plan. So basically, there is, for the really low-income people, but who are falling in that $30,000 to $40,000 bracket, there's a choice. You can go in the Medicaid expansion route, or if you happen to want to buy a plan on the exchange, you get a heavily discounted plan. That was the general plan, but things changed. Firstly, the way the PPACA was going to get the young healthies who might think they're invulnerable and I'm 25 or I'm 28 and I have amazing health. Why do I need to waste my money on health insurance? I would rather buy a nicer car, whatever. The young invulnerables, as they're called in the literature, they had to be brought into the pool. So when President Obama passed the Affordable Care Act, the big thing that all of us health economists complained about so much was that the individual mandate that you have to buy health insurance and otherwise you have to pay a fine, we said that fine is ridiculously low. That fine is like barely a slap on the wrist. That fine is not going to make anybody come into the market, as opposed to a place like Germany, where your fine is basically equal to your premium. So if you don't buy a plan, the government's going to take the money from you and it's a fine anyway. So people go, well, in that case, we might as well buy the plan. Ironically, that shortcoming of the Affordable Care Act, the fact that the fines were too low, is probably what saved it, because when President Trump came into office, the first thing he did was he revoked the individual mandate and he said no fines. And we were like going, oh my God, does this mean premiums are going to skyrocket because the young healthies who don't want to be in the pool now will just not be there? Well, it turns out the fine was so weak and low anyways, repealing the fine did almost nothing. So in that weakness might have actually saved the Affordable Care Act, because the moment President Trump repealed the individual mandate, some of the red states, red-leaning states politically sued and said, oh, well, now that the individual mandate is gone, we shouldn't have the Affordable Care Act at all because all the healthy people will leave. And the Supreme Court said, no, we are not touching that because it's really not doing anything. So individual mandate gone, but the Affordable Care Act has survived that bump. The premium supports continue to have been expanded. Now, Medicaid expansion, one of the things that I learned while the whole Affordable Care Act thing was going on is how little power the federal government and the president actually has to make the states do something. The only thing they can do is offer some financial carrots and financial sticks. And in this case, the financial carrot was, hey, if you expand Medicaid, we will cover like 90% plus of that additional cost because you're covering more people. And then the stick that they tried was, and by the way, if you don't expand Medicaid, the current federal support you get for your Medicaid programs, we are going to withdraw that. And the states sued, saying, no, that's not fair, that's too stringent, they can't just like force us to, and it went to the Supreme Court, and the Supreme Court said, yeah, that's too stringent, the federal government cannot do that, and so Medicaid expansion decisions are going to be left to the states. And states can choose whether they will expand Medicaid and cover all adults up to that 133% of the federal poverty level, or they can choose not to and stay as it is. And yeah, for the states that did choose, there was actually that 90+% funding match did happen. So Affordable Care Act went into effect, but it went into effect with this like drawback that Medicaid expansion was left to the states. And so if we actually look at what it did, the Affordable Care Act was signed into law in 2010. And at that point, you have about 48.2 million non-elderly uninsured people. And then the actual exchanges go into effect right around 2013. That's when. And as you notice, right after that, uninsurance rates just like plunge. So they plunge really low. So went from 44 million uninsured to 28.4. And then there was a slight uptick again after President Trump comes into office and he repeals the mandate, so no fine. So some people leave, but then interestingly, it comes down again. So I guess some people went, all right, I don't want insurance because, you know, I'm no longer paying even that trivial little fine. And then some of them said, well, on second thoughts, after 1 year of being uninsured, I think I want to go back to being insured. So now, so we still have 30 million uninsured non-elderly adults. So where is this coming from? Well, this is coming from primarily three sources. One is non-elderly adults who are undocumented immigrants, because none of these provisions will actually cover undocumented immigrants. Uninsured adults who are voluntarily choosing not to go on the exchanges, again, possibly younger and healthier people. And finally, the low-income people in the states that did not expand Medicaid. So those are now the primary sources of uninsured in the US. So what I would love to do is just see whether you have a sense, as of now, as of today, where are we with respect to how many states out of the 50 states that US have not yet expanded Medicaid? So that's our next poll. So Rachel. Take your best guess. Okay, so I'm assuming, Rachel, is everybody able to see the poll results?
Let me end it and share results. Okay, you guys should be able to see it.
Okay. So interestingly, what I'm seeing here is the answer that 1 is 16, followed by 25, followed by 10. 10 is actually the correct answer. So as of now, literally as of today, this map is what this looks like. You have pink states, which it's adopted and it's in effect. The blue and the purple states is it's been adopted in some form of modified form, not fully rolled out yet. And North Carolina is where the legislature has voted to adopt, the governor has agreed, but it has not yet gone into effect. As of now, we have 10 holdouts, and one of those is Alabama, sadly, and we are surrounded by other holdouts. So Mississippi, Tennessee, Georgia, Florida, none of those have expanded, and neither has South Carolina, Texas, Wyoming, Wisconsin, and Kansas. So these are the last states that are holding out. Now, in some cases, the states, Arkansas is like a classic example. They expanded Medicaid, but for possible, be it for political reasons, etc., they gave it its own name. So it's like, well, we didn't really just expand Medicaid under Affordable Care Act. We expanded it, but we did it better, and so they gave it another name. And so that's fine. I'm very much of the opinion, I don't care what name you give it, as long as you actually do this, because more and more and more evidence is emerging that Medicaid expansion is economically a very good decision for the states. So one of the terms you will hear tossed around sometimes in context of the Affordable Care Act is the coverage gap. So let's see where that is. Remember the way it worked in the Affordable Care Act. Medicaid was supposed to cover people up to 133% of the federal poverty level. And then from 100% of the federal poverty level, subsidies, very generous subsidies, were there if you were buying health insurance off the marketplace. So basically, if you were between 100% and 133%, then you were fine. You could go to the marketplace and buy this very highly subsidized level. What if you are under 100% of the federal poverty level? In other words, if you are a really poor adult, where for a family of 4, your income is below $30,000 actually, I'm not sure, it could even be lower than 30,000 for a family of 4. I should have looked up the exact number for this year. Apologize for that. So once the Supreme Court kicked the decisions back to the states, saying, it's up to the states if if they're going to expand Medicaid or not, President Obama's administration tried to say, well, at the minimum then, let's also give good, strong, big subsidies to adults below that federal poverty level, should they sign up. Except this is 2012. The midterm elections have happened. Now both the House and the Senate are being controlled by Republicans. And so when President Obama wanted to expand the subsidies to cover adults below the federal poverty level, they were like, no. So somebody who was below the federal poverty level, if they tried to buy health insurance on the exchange, they would be paying the same premium as wealthy Americans do, people who are above 400% of the federal poverty level. So obviously none of them can afford it. So that's your coverage gap right there. Low-income adults in states that have not expanded Medicaid, which is around the time when where people say, well, who is covered under Medicaid already? In Alabama, for example, you're covered by Medicaid if you're a child under the age of 19, so all the way through age 18, if you're if your family income is below the federal poverty level. Actually, if your family income is up to 133% of the federal poverty level, children are covered. Low-income women are covered when they're pregnant and for a certain period after they give birth or the pregnancy ends. Disabled people, people who are disabled enough to be on supplementary security income, ergo they are not working or they cannot work. And then people with very specific severe disabilities like advanced cancer, kidney failure, blindness, there's like a narrow strip. Finally, low-income adults who have children in the family, so not if you don't have children in the family, and you're incredibly poor. How poor? Well, family of 3, your annual income would have to be less than $9,000 a year. Every time I present this to like a business forum or something, people ask me if that's a typo. No, it's not a typo. $9,000 a year. You have to be less than that. By my calculations, if you had a 20 hours a week job at the minimum wage, your family income goes above that. So it's really quite prohibitive. So you have this big pool of people who, as a result, are lacking health insurance coverage. And of course, they are the most vulnerable people in the state. So this is, again, I should acknowledge that this is like from Parka. That's how I got this really nice figure. So right now, if I just take a very, very quick look at who is covered under Medicaid in Alabama, and then where is the Medicaid expenditure going, I want you to pay attention to this. 22% is people with disabilities, but they account for 46% of Medicaid's expenditure. And while 52% are children, they account for about 25% of Medicaid's expenditure. And then, of course, yes, the other group I forgot to mention, these are the low-income seniors. These are people who are above 65. They're eligible for Medicare, But if you're also low income, then Medicaid will pay for certain expenses like nursing home care. And then finally, the group that's other, that's picking up your pregnant, low-income pregnant people and so forth. These slides have probably been shared. I strongly, strongly advise you, if you're interested in this, take a look at this PDF file, which was Parker's report. This was a roundtable that we did with several big business people of Alabama, sort of explaining to them why Medicaid expansion is probably a good idea for Alabama, because it's turned out to be very economically beneficial to the states that did expand it. We really like to look at Louisiana. Louisiana expanded theirs in 2017 when a Democratic governor came into power. And, you know, it's a poor southern state, high share of minority people. And so their experience when they expanded Medicaid is probably a good blueprint for what Alabama might expect. And Parker's report is excellent. My colleague, Dr. David Becker, is also very well known for his work in this area. He's done some very detailed economic analyses, which are also available publicly. So what's going on here? Basically, they found that if Parker estimated that if we expand Medicaid in Alabama, it's probably going to increase our enrollment by about 283,000 people. And it's probably going to cost 25.4 million straight in additional expenses. But remember, the federal government is going to pick up the vast majority of that. Right now, the federal government, for every dollar spent on Alabama's Medicaid, the federal government pays about 78 cents and the state pays 22 cents. Medicaid expansion, that population means the federal government would pay 90% plus of those costs. So ironically, this is actually going to yield savings in many, many ways that I'm going to actually discuss in the next slide. And because this also means that the health system will be expanded, this is anticipated to create an average of 20,000 plus new jobs in the next few years. I think most of you, I don't think you can be in the world of health and medicine right now in Alabama without knowing that our rural hospitals are struggling and failing. And one of the big reasons why they're failing is the lack of revenue from patients and also the lack of additional payments from the federal government. The federal government used to pay rural hospitals something called disproportionate share payments, and that was for their treating uninsured people. Because the Affordable Care Act was supposed to drastically reduce the number of uninsured people, there was also a provision that, okay, so the disproportionate share payments will also be scaled back. So that's one source of hurt. But the other source of hurt simply is uninsured people don't really go to the healthcare system unless they are extremely sick. And so basically the hospitals are missing out on a pool of people with low intensity health conditions, which if caught early and treated early would probably be beneficial. But they're missing out on those patients because those patients are uninsured, and so they're not going to the hospitals. So that ties into why would providing this additional health insurance reduce Medicaid's cost? A huge part is it would reduce Medicaid costs by allowing early detection and treatment of many diseases. For example, breast cancer. If a low-income woman is diagnosed with breast cancer, then she is treated under Medicaid. But the question is, how is she diagnosed? Because if she doesn't have coverage, then she's not going for routine mammogram screenings. Routine mammogram screenings have the best chances of catching breast cancer when it's still at the stage 1 level and can probably be treated less expensively and have a good success rate of saving this person's life. Otherwise, this low-income woman is waiting till she feels such discomfort or so sick that she goes to a doctor, even though she doesn't have insurance. Then the doctor looks at her and goes, oh, okay, looks like you have advanced breast cancer. Now she's put on Medicaid. And now she's probably like a stage 4. It's much more difficult to treat her. It's much more expensive to treat her. And the chances that you will be able to save her life with all that treatment is actually much lower. So it's like a lose-lose. You're catching these patients when they're sicker, more advanced stage of disease. You're spending significantly more resources treating them. And chances are they're probably still dying. So this is one source of tremendous predicted savings, that you're going to be able to catch a lot of these diseases early through regular screening. Reduce the burden of uncompensated care. Rural hospitals are struggling, but when even urban hospitals end up treating somebody who's uninsured, there's no reimbursement beyond that disproportionate share payment that's coming. Well, what happens is that payment just gets, the hospital's losses are either picked up by taxpayers, or what the hospitals charge to insured patients actually goes up, which in turn means your insured patients' premiums go up in the next round. One huge issue is states that have expanded Medicaid are actually finding that it increases their labor force participation rates. Why? Well, 2 things happen. One group that is eligible for Medicaid right now in states like Alabama is those who are disabled and unable to work and eligible for supplementary security income. The condition for being on supplementary security income is that you're too sick to work. So very often, these people go on supplementary security income, they get treated with Medicaid, and then they get better. So they're moderately disabled people. They could participate in the labor force, except in Alabama and the other 9 states that haven't expanded Medicaid, the moment they start participating in the labor force, they're no longer eligible for supplementary security income. They lose their health insurance coverage. So you're keeping people out of the labor force, whereas the states that have expanded Medicaid have all seen moderate increases in their overall labor force participation because the moderately disabled people are going back to work. Finally, we have so many programs around the state that are sort of want to help people ramp off poverty and, get into a better lifestyle while working. So here's the thing. Let's say I am a low-income mother, extremely low-income mother, the less than $9,000 per year. And I have something like, diabetes, so I occasionally need insulin to control that. It's not advanced, it's not something that's deeply debilitating, but it needs to be controlled through medication. My first job is not going to be like a $75,000 job that's going to give me great employer provided health insurance. My first job might be working at a fast food joint, making minimum wages, and maybe I'm not even working full-time. Maybe I'm working 30 hours a week, and maybe I've been told, well, after 2 years of that, we'll make you full-time. Well, guess what? When I work 30 hours a week at minimum wage, I'm now not poor enough to be covered by Medicaid. Hence, I'm going to lose my Medicaid coverage, and my diabetes, which is currently controlled, is going to go out of control. The agencies and nonprofits that work with such low-income people go, in all fairness, in all humanness, we can't tell them to get jobs because it's going to actually make the situation worse for them because they lose their Medicaid coverage. Whereas if they knew that they just have Medicaid coverage all the way till 133% of the federal poverty level, you can actually take that work opportunity. And again, study after study in the states that have expanded Medicaid show, yeah, people, if they can work without it making them worse off, mostly do want to work because everybody likes the improvement in your family standard of living when there is some wage income coming in. And I covered this already, so this is sort of it's also going to be this much needed lifeline to rural hospitals. Another link I've put in there is when the Alabama Hospitals Association has gone to the Alabama state legislature and said, guys, will you please expand Medicaid because it is going to be so essential for our state's rural hospitals to survive. I was recently contacted by one of the big nonprofits working, going, will you do one more round of television and writing editorials and the rest of it, explaining to the state legislatures what I just said to all of you in the previous slide, how this will actually work or help with Alabama workforce, because this is a huge problem. Alabama is staring into this shortfall of mid to mid-skilled blue-collar workers. That's kind of that like gap where that shortfall is. And by the way, that's not a shortfall you can cover through immigration, because the Immigration and Naturalization Service does not give you work visas for blue-collar workers where the job does not require a college degree, etc. So that's a problem. And one obvious fix, it won't be a complete fix, but one obvious fix, again, would be expand Medicaid, let the people with moderate disabilities go into work, let the parents who have kids and are extremely poor at least know that they can get on the job training without losing their Medicaid coverage. So this is probably something to consider. I know there is conversation in the governor's office, etc. right now. I don't know how it will play out. But one of the things that, apart from this extreme scrutinizing of the role of Medicaid expansion and workforce development, one of the good things that has happened is Alabama has expanded postpartum coverage for all women low income up to the federal poverty level. Previously, they would be covered for 2 months after giving birth. Now they are covered for 12 months after giving birth. And the biggest implication of this is that all kinds of conditions that might be associated with postpartum state, which include postpartum depression, which could include continuous diabetes if you develop gestational diabetes, which also could include health conditions that were detected, but they can't really be treated safely while you are pregnant. Well, sure, things can be treated in the 60 days post-pregnancy, but even for relatively well-off women, the first 2 months after giving birth is kind of crazy. And when you're looking at somebody who's low income on top of that, she simply might not be able to get to a doctor within the 60 days after giving birth to initiate all these treatments. Well, now at least they have 12 months. So this has happened, and we are doing evaluations to see how well this works and how well this is having the effects that we hope it has.
Dr.
But
Sin,
yes.
we have 2 questions in the chat. Would you like
Okay.
to answer them?
Actually, this is my last slide. So after this, I
Oh.
was just going to open it up all up for questions. So
Perfect. You go ahead.
I'm going to, I'll keep the slides up and go ahead. Can
Okay.
I see the chat? Okay, I can.
You should be able to. Naomi asked, what is the main pushback against Medicaid expansion when it presents so many advantages?
So, you are recording me, darn it.
Oh,
Okay.
yeah.
No, honestly, I think the main pushback is purely political because politicians are afraid that there will be a primary challenge if they are found to support something that is linked to a Democratic president. And a standard comment I've made is, for heaven's sake, do what Arkansas did. Call it something else. Don't call it Obamacare. You know, pick your favorite football coach, name it after them, and expand it so that you have that political cover that, oh, no, you didn't do Obamacare, you did Nick Saban care, whatever. And I suspect if we ever do see Medicaid expansion happen, then that's probably the route they'll take. One of the panels I was on, and I was on with Ryan Hankins from Parka, and I was on with the past CEO of the UAB Health Systems, and we had 2 Republican legislators on that panel with us, and they were supposed to tell us the negatives of expanding Medicaid, and honestly, they didn't have an answer. The best they could come, one of them kept saying, well, I don't really know the details because I haven't really read up on it. And the other kept trying to say, well, you know, the Alabama budget is just so complicated. So we didn't really get any real reasons. So I really, really suspect it's mostly just like a political issue. And the next question, this is from Morgan, should we call right to our state representatives, advocates? Yes, please, because one of the things we know is not all state representatives and advocates are actually educated on this issue. They don't get this full lesson in health economics and health policy. And so they probably also go with a lot of knee-jerk reactions like, oh, it's going to cost the state a lot of money and it'll just make a bunch of people stop working. Because the biggest thing we always hear about these programs is, oh, you're just going to give people a way to stop working and sit at home. And then you've got to go, no, 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 no. This is actually going to help people work because it's helped people get into the labor force in other states that look quite like Alabama. So this is actually a support system that allows people to enter the labor force, take their part-time jobs, take their temp jobs, get trained till they eventually get to the kind of jobs that really allows for a secure lifestyle. So yes, I think the more legislators who know this, the better. My personal experience talking to legislators and business groups is that the things they pay most attention to is, yes, it's going to be helpful for labor force participation. And yes, it's going to save money because you have a much better chance of catching somebody at stage 1 of cancer than stage 4 of cancer, where you'll spend a whole bunch of money treating them. And you're probably not going to be able to save their lives anyways. My other favorite pet peeve is hepatitis C, where we can't treat people with hep C at early stages. But by the way, when the disease advances enough so that they have organ failure, that's when they go on Medicaid. And that's when Medicaid starts spending money trying to treat them. It's quite exasperating that way, like how impractical this is. Okay, do we have other questions? If we don't have other questions, Rachel, will you just share my I know you recorded this and the slides are there. And if you would just share my email with everybody who attended today as well, I'm always happy to take further questions.
Yes. Well, thank you so much for presenting to us. I think they really got a lot out of that. Scholars, will you fill out this survey and let us know how it went? Yeah, everybody say thank you to her. Yep. Okay. Okay, thank you so much, Dr. Sin.
Perfect. Thank you.
Yes.
Thank you, Dr. Sin.
Thank you. I enjoyed this. Thank you for the many kind comments in the chat. I appreciate that.
I will send everybody the recording and the follow-up and everything. So thank you guys so much. You guys have a great day.
Thanks, Rachel. Have a good one.
Yeah. You as well, Marcus.